thank you to Vitaflo for inviting me today to speak to you about managing the preterm infant diagnosed with PKU. So this slide is just to highlight the treatment for the infant with PKU. So we tried to we implement a restricted phenylalanine diet. That could either be by restricting the infant formula or breast milk if the baby is breastfeeding, and then introducing a fee-free tyrosine-rich amino acid supplement, with trying to aim for a total protein of 3 grams per kilogram and providing adequate energy for growth. So before I go into presenting about the case I'm going to talk about today, I thought I would just present 2 of the papers I found when I did some literature research when I was presented with the case of a baby born at 25 weeks and was diagnosed with PKU. So the first paper I came across was a case report from Spain of a preterm infant born at 29 weeks, and they weighed 1.29 kilos. At the time of diagnosis, they were having enteral feeds of expressed breast milk, which was being fortified with breast milk fortifier, and they were getting about 3.5 grams of protein per kilo. The newborn screening was taken on day 16, and it was reported to only be 420 micromoles of Phe. They still initiated treatment even at this level, and they did that by implementing a fee-free formula and breastfeeding in combination, and they were giving 2.5 grams of protein from the fee-free formula and 1 gram from the expressed breast milk. They found that the Phe level normalized and subsequent amino acid levels in the blood and urine were all normal, and the confirmation test for PKU came back negative, and they just reintroduced normal feeding at this point. This was a case of transient hyperphenylalaninemia, secondary to delayed maturation of the hydroxylation enzyme system. Levels of Phe decreased with time and without causing any symptoms. The authors reported that they felt it was necessary to treat this patient with a Phe restriction due to the risk of neurological involvement, especially in a patient at such a young age. The second paper I want to speak about was the one I could find closest in age to the child that we had at Bristol Children's. The case reports of a premature infant born at 27 weeks weighing 1,000 grams. And their newborn screening level was a Phe of 2,800, and this was taken on day 7 of life. They started treatment of 5 days of intravenous lipids and glucose, as well as small amounts of Phe-free formula to provide the protein. Due to the poor growth for this child, they introduced a Phe-reduced branched-chain amino acid-enriched PN to the child's dietary treatment. And they found that they were able to normalize Phe levels by day 19. They report that at 14 months of age, the child is now growing really well in the 25th to 50th centiles and has normal results for all formally tested psychomotor development. They report a good outcome in spite of 2 weeks of extremely high Phe concentrations, and this suggests that the premature brain may still have enough plasticity to recover. So, going on to the case that I've come today to talk to you about, this little girl was born at 25 weeks plus 1 gestation via spontaneous vaginal delivery after the mother presented with abdominal pain and PV bleeding. She was intubated and placed in an incubator after a quick cuddle with mom, and she was born at 800 grams, which to me of the newborn is really, really light, but is actually quite good. She was on the 50th centile, so she was at a good birth weight for her age. Neurologically, she had IVH grade 3. She had anemia of prematurity and did require 4 red blood cell transfusions and 2 platelet transfusions. And this was all before she came to us in Bristol. Her respiratory system, she was ventilated for 14 days, and there were delays in weaning the ventilation due to increased apnea and bradycardia. She did have neonatal jaundice associated with her preterm delivery, and that was treated by the standard phototherapy treatment. And at the time that we got to know her, she was on TPN with SMOF as the lipid source, and she had a slow introduction of maternal enteral expressed breast milk. So, guess what day I got this diagnosis? Yes, Friday afternoon while I was in PKU clinic, so that was great. So her routine blood spot was, her screen was taken on day 13, and the result was reported on day 15. She had a Phe level of 813, and her tyrosine was 36. At the time of diagnosis, she was on a good amount of EBM, so they were quite happy with how she was doing, progressing with her feeds. She was on about 105 mils per kilo and 45 mils per kilo of PN. Just to say here that usually premature infants do have newborn screening by day 5, just there were delays in hers because of her blood transfusions that she was having. So, what we decided on that Friday afternoon very quickly was her level wasn't so classical PKU where it was over 1,000, but we didn't really know that 800 would it have been higher if she hadn't had those blood transfusions? We don't really know, but we went in with 25 milligrams per Phe per kilogram, and then knowing what allowance we had fluid-wise, worked out how much expressed breast milk we could get to restrict her natural protein, and then worked out if we were to introduce a Phe formula, what volume that could provide, what was left over. We did advise to the NICU team, because she was born in Derriford, that because it's a term formula, there are no preterm formulas available that are Phe-free. The introduction of this needs to be done really slowly and cautiously because of the increased risk of developing necrotizing enterocolitis, and that they may need to increase the PN that she was having to provide more lipid and glucose to make sure we meet her energy requirements. I think just as a side note, because it's happened to me again recently with another newborn screening diagnosis, that I just want to make note of that in premature infants and the complications of NICU treatments, it can make it really difficult for the newborn screening results to test, to interpret them, because NICU patients may need to be screened more than once. And babies that are born before 32 weeks, they will be screened a second time at 28 days of life to check for the hyperthyroidism that's on the newborn screening as well. So things that could interfere with that is late feeding. We want our babies to be to try and have good milk feeds for at least 48 hours before we do the screening. Antibiotic therapies have been known to make it hard to interpret the results. Parenteral nutrition as well. And then blood transfusions delaying when the results are done, because the baby's own blood will have blood from different compositions, so it could delay their actual results. So our little girl, when I came in on Monday, I was actually surprised that they had reported for her to have gone up so well on the PKU Animix at this time. So she was on about 3.5 mils. It's so small, these feed volumes. It took my head getting used to it. Took time to get used to it. And so 3.5 mils 2 hourly, and she was on 3 mils 2 hourly of Animix infant. And then she was receiving 10% dextrose and smophilipid at 3 mils. This was giving her 96 calories per kilogram and just under 1.5 grams of protein. And her Phe intake was just under 23 milligrams per kilo. So I was surprised that they had increased so much. So we said, well, keep increasing as tolerated, and we'll see where we can go, because we needed to give her more protein and more energy for growth. And unfortunately, on day 23, she had a distended abdomen, and the decision was made to bring her up to our intensive care unit, in our neonatal intensive care unit at Bristol Children's, and she was diagnosed with necrotizing enterocolitis. She was made nil by mouth, the triple antibiotic therapy started, and she was placed fully on PN. Derriford doesn't have access to making bespoke PN bags, so she was on a standard bag, which was providing her about 3.76 grams of protein per kilo. We decided to reduce that down to 3.5, and that was based on the information that protein requirements for preterm neonates that weigh less than 1 kilogram. When they're enterally fed, they usually have about 4 to 4.5 grams of protein per kilo, but the consensus for PN is 3 to 3.5. So we thought we'd aim with 3.5 to give her the benefit to have the much protein to aid her growth at this time. So we reduced that down, and then we made up the calories and fluid with dextrose, 10% dextrose. So after she came up to us and had surgery, during surgery, she was found to have a necrotic perforated bowel with curds of formula causing a plug. She had 60 centimeters of intestine that were relatively healthy looking, so they were able to preserve this by resecting the necrotic gut and creating ileostomy. So at the time of surgery, she was still growing really well. She had a weight of 1.22 kilos. She was still on the 50th centile. Her height and her head circumference were on the 2nd centile at this time. I will note here, because the surgeon said that she had to remain nil by mouth for 10 days, and this is when we really decided we need to consider how can we access fee-free PN. There is no source that we could find in this country. We did find a source in the United States, but the stability of the product and getting it over here and all the regulations, it was just too much of a minefield for us to be able to do. And then our trust was saying the regulations that that company was using, they weren't sure if they were happy with those standards, so they wouldn't allow us to use it with her anyway. So just to note here, you can see this is her growth chart. So this is when surgery was, and this is when we reduced her down from 3.5 to 2.5 grams per kilo, and you can see it really did affect her growth. And she was, this is what we were doing for at least 10 days when she was post-operation. So just looking at her Phe levels here, we have her diagnosis level, which is just over 800. And you can see here it dropped, and we thought, oh wow, the treatment that we put in place that Friday afternoon was having an impact, but actually it was because she had blood transfusions that her levels went down. And here, this is where she became unwell and had developed neck. Her level was over 1,200. And then post-surgery, due to the stress of the surgery, her levels went 1,200 or over 1,300. What we also found at the same time was after surgery, her tyrosine levels dropped considerably, and they went down to less than 10. I would like to say a big thank you to the BIMDD dietitian group, because when I put out that I had this query, lots of people got back in touch with me with support and other cases that they'd had. And Rachel Skeeth from Great Ormond Street shared her case of a 20-week-old Prem child that she found one of her rate-limiting steps as well was tyrosine, and she supplemented the tyrosine. This is where we decided we needed to try and do this, because we weren't going to be able to use the fee-free formula, because the NICU consultant said we don't want you using this. It's a term formula. The infant has had all this surgery now, so we have to be really careful in introductions of feeds. So we thought, well, if we introduce just the amino acid supplementation of tyrosine, will this help? So when we were allowed to start feeding her, we had to follow the NICU protocol. So she started at 1 ml 4 hourly for 6 feeds, so 6 mils in a 24-hour period for 2 days. And if she tolerated that, that could go to 2 hourly. And then we went up, started introducing the tyrosine. We chose a goal of about 100. We thought we'd start with 100 milligrams per kilo of tyrosine, looking at the literature research out there, and then looking at how much tyrosine is provided from a fee-free formula at 150 mils per kilo. It was about 330 milligrams per kilogram. So we thought, we'll start at 100, see where we get to, because we want to introduce the least amount of possible. And we introduced that slowly. It was really well tolerated, I'm glad to report. And we found that with the PN, we were actually able to give her 3 grams per kilo of protein, and she was on 154 milligrams of Phe at this time. And just showing you as we introduced the tyrosine, so we started at 50 milligrams just to see how she would tolerate it. It didn't make much change in her levels, so then we went to the 100 milligrams, and it still wasn't making a difference, so we introduced to 200 milligrams, and this is where we finally saw her achieve appropriate levels of tyrosine. And just to show how that correlated with her tyrosine and Phe level, so we introduced a tyrosine supplementation, and you can see here we finally got her 3 consecutive levels of Phe in range, and that was by day 56. So it took quite a long time for us to achieve stability for her. Well, she did really well, and we managed to progress with enteral feeding, and we got to the point where we were able to start weaning her TPN. So she was 13 weeks uncorrected, or termed 37 weeks corrected. And at this point, she was on 20 mils of express breast milk 2 hourly, and this was via NG and also bottle feeding, so she started to be able to bottle feed at this time. And we hadn't been increasing the tyrosine. We were kind of just letting her grow out of it and seeing where we were going if we needed to increase the supplementation. But at this point in time, she was only getting 1.7 grams per kilo of protein, and we felt me and Abby both at this time were quite nervous about that. There's not very much for a premature infant to be getting. So we were finally given the go-ahead to introduce a fee-free formula. Parents were extremely anxious and they wanted to use a different formula, so at this point in time we used PKU Start. And she tolerated this really well. We got her up to 12 mils per feed relatively fast, and her growth at this point in time was on the 2nd centile for weight and head and height on the 0.4th. Once she was orally fed, she was able to go back to Derriford so she could be closer to home. And they had been restricting her fluid at that point to about 180 mils per kilo. And she was getting just under the 3 grams of protein per kilo, but her weight had fallen to the 0.4th centile. Then she was finally allowed to go home, and Mum had stopped expressing breast milk, and she switched over to standard infant formula. And we just let her demand feed the PKU Start after, and boy, did she make up for it, because she was drinking a lot, almost 240 mils per kilo, energy of 160 calories per kilo, and 3.9 grams of protein per kilogram. But her weight was still in the 0.4 centile, so it took a while for her to catch up. What we did find, though, when she went home and was drinking good amounts of the fee formula, her Phe levels went down to less than 50, and we were just chasing her. She was growing so fast at this point in time to catch up that we were just going up by 1 gram exchange, or 1.5 gram even, just to keep up with her. And she did get levels into range, and she was on about 8 exchanges at the point in time. So it's gone up from about 3 to 8, so that was good. So weaning, so it's documented in the literature that premature infants should start weaning between 5 to 8 months uncorrected. So at 25 weeks, parents felt she was ready. She was on 8 exchanges of infant formula, PKU Start that day, at that time, and managing about 4.2 grams of protein per kilo. That's the combination of all the protein. So her weight was still not so great. But you can see here on this growth chart that we started weaning here, and then it slowly just started to creep up and get better. And so solids really did help with that. Today, she's doing really well. So she's 9 months, 29 weeks corrected, and she's on 9 exchanges on a combination of food and formula. She's started a 2nd stage protein supplement of PKU Explore. Still drinking PKU Start, and she's having about 3 to 3.4 grams of protein per kilo. Her growth is really good now. She's on the 9th centile for weight, height, and head circumference, so I'm very happy about that. And her mother sent me a lovely little picture of her, so she's doing really well. We'll wait and see how she is, but at the moment, everyone's really happy with her development. And last clinic, when we were down in Plymouth, Mum, as she was leaving, "Oh yes, I'm pregnant, by the way." And we're like, "Oh no, how many weeks are you?" And she was already 20 weeks at that point in time. And the reason why she was born early is because the mother has a hormone deficiency in her placenta, so we're waiting, this baby could come. I think she's 27 weeks when I spoke with her yesterday, so she's gone past where she was with Effie. Sorry. Yes, so yeah, but we're waiting to see what happens there. So I think things I took away from this case was that although the predicted incidence of prematurity in PKU is 1 in 800,000, it was really hard to manage her without having access to a fee-free PN solution. The tyrosine supplementation played a key role in getting her phenylalanine levels down into the stable range. And I would definitely urge caution anyone thinking of using a fee-free formula that is for term infants in the premature infant. And I think this infant was 25 weeks. When she was 25 weeks gestation when she was born. All the other literature that did use the formula, they're a bit older, and those weeks make such a difference in their gut development. So just be cautious. Thank you for listening.